Okay, welcome to the deep dive.
Glad to be here.
So you brought this stack of sources. Looks like they're all focused on antiemetics, the drugs used to fight nausea and vomiting, especially with chemotherapy.
Yeah, that's right. It's often one of the toughest side effects for patients. Really impacts quality of life, even their ability to, stick with the treatment. These sources give a good overview of what's available.
Absolutely. So our mission today, let's try and quickly unpack this. We want to get a handle on the main types of these medications, how they actually work, side effects, definitely, and also those really specific things like when to use them, or just as important, when not to, pulling out the key info.
Exactly. And there is some interesting details in there, like why you absolutely have to use some in combination, or some pretty surprising ways they can be given. It's not always straightforward.
Right. Things like skin patches, or why one dose might last days, or how they interact with newer cancer therapies. Okay, let's dive in. First big category the sources mention.
That'd be the serotonin 3 receptor antagonist, often called the satrons.
The Cetrons, okay.
Yeah.
And the specific names mentioned.
Let's see. Dolestron, Granestron, Ondansetron, and Polonocitron. Those are the main ones discussed.
Got it. So serotonin 3 antagonists, how do they work? Where are they acting?
Well, they block serotonin receptors, and they do this in two main places, according to these sources. Peripherally so, basically in your gut, the GI tract,
Okay.
and also centrally, up in the medulla, part of the brainstem that, controls things like the vomiting reflex. Blocking serotonin there helps stop those nausea signals.
Right, hitting it from both angles, the gut and the brain's command center. Makes sense. What about side effects? What are the common ones?
The sources are pretty consistent here. Headache and constipation seem to be the most frequent, popping up in maybe 10–15% of patients.
Okay, headache, constipation. Anything more serious to be aware of?
Yes, they do mention potential increases in liver function tests
Mm-hmm.
and also QT prolongation.
QT prolongation. That's
Yeah,
the heart rhythm thing, right? On an EKG.
exactly. It's an electrical change. The concern is it can sometimes increase the risk, albeit usually slightly, of certain arrhythmias. The sources flag this, especially with really high doses or if it's given too quickly through an IV. So it's something doctors watch for.
Definitely important. Now, here's a practical point the sources brought up. When you're choosing between, say, ondansetron and granestron, is one generally better, more effective?
This is interesting. The sources actually state that dolestron, granestron, ondansetron, and polonocitron are all considered, well, pretty much equally effective, assuming you use equivalent doses.
Huh. So that work equally well.
Then the choice often boils down to other things, like cost, which is huge, obviously, or what drugs a specific hospital or clinic has on contract. More logistics than pure clinical difference in many cases.
That's a really key point for how things work in practice. Shifts us from just efficacy to, well, practicalities. And they come in different forms, right? Not just pills.
They do. Granestron and ondansetron, you can get them as oral tablets or liquids, and also parenterally, injections or IVs.
Uh-huh.
Ondansetron also comes as an orally disintegrating tablet.
Yeah.
Melts in your mouth, which is great if swallowing is tough.
Yeah, that'd be helpful.
Oh, and a specific note on dolestron, the sources say it's now mostly just indicated for CINV, chemo-induced nausea and vomiting, and only the oral form. Less used now, it seems.
Okay. And I think I saw something about some less common, sort of unique delivery methods for granestron.
Yes, this is where you see some innovation. Grandestron has a transdermal patch. It's 34.3 milligrams. You put it on the skin, usually a day or two before chemo starts,
A patch? How long does it last?
up to 7 days.
Wow, 7 days from one patch.
Yep. And there's also an extended release subcutaneous form. That's an injection just under the skin, 10 milligrams, given at least 30 minutes before chemo. And it's designed to last, so you wouldn't give it more often than every 7 days either.
A patch or once weekly shot. That sounds way better than multiple daily pills for some patients. Huge convenience factor. Okay, let's zoom in on polonocetron for a minute. The sources seem to give it special attention. What's different about it?
Right, polonocetron, it does have a distinct profile. The sources highlight its indication for preventing acute CINV, that's the nausea right after chemo, especially with the really highly emetogenic stuff.
Okay.
But importantly, it's also indicated for both acute and delayed CINV with moderately emetogenic chemo. So it covers that later nausea too in those cases.
Acute and delayed, that's broader coverage. How about how long it lasts in the body?
That's the really big difference. Its half-life is much longer than the others in the class, around 40 hours.
40 hours compared to maybe just a few hours for the others? That's significant.
It is. It means, practically speaking, one single dose of polonosetron might be enough to protect a patient through, say, a 3-day chemotherapy regimen.
Instead of needing daily doses of the other ones.
Exactly. Could replace multiple oral or IV doses. Big win for simplicity.
So it just hangs around longer, providing that extended shield. What's the usual IV dose?
It's quite small, actually. 0.25 milligrams. Given as an IV push, usually about 30 minutes before chemo starts.
And is there a plain oral pill form?
Ah, good question. The sources are very clear on this. The oral capsule of colonosetron isn't available by itself. It only comes as part of a combination product.
A combo product. With what?
With an NK1 antagonist. We'll probably get to those later. But yeah, you can't just get an oral polonosetron pill alone.
Okay, that's a crucial prescribing detail. It comes bundled. And side effects, same as the others.
Pretty much, yeah. The sources list the same main ones. Headache and constipation. Consistent with the rest of the class.
That gives us a really good picture of the serotonin blockers, the cetrons. Let's shift gears. The sources also talk about corticosteroids.
Right. Drugs like dexamethasone, sometimes methylprednisolone, used as antiemetics too.
Dexamethasone is a common one. Do the sources explain how steroids work against nausea? Is it well understood?
You know, it's funny, the sources actually state the exact mechanism isn't fully known.
Really? For such commonly used drugs?
Yeah. The leading theory, though, is that they might work by inhibiting prostaglandin synthesis up at the cortex, part of the brain.
Prostaglandins. Those
Yeah,
are involved in inflammation and stuff.
Right, chemical messengers. So the idea is steroids interfere with some signaling pathway there, but it's definitely less clear-cut than how the serotonin blockers work. Still a bit of a black box.
Interesting. Okay, so maybe a bit mysterious, but they work. What about side effects when you're just using them for a short course for nausea, not long-term steroid use?
For these short bursts, like single dose or just a few days, the sources say side effects are generally infrequent.
Okay.
But they can happen. Things like maybe feeling a bit euphoric or anxious, maybe trouble sleeping, increased appetite, sometimes hiccups, mild fluid retention.
Hiccups. Okay.
And there's one specific one they mentioned with rapid IV administration. Sometimes patients get this weird transient but quite intense burning feeling down in the perineal area.
Whoa. Okay, definitely something to warn patients about if they're getting it IV fast. You mentioned dexamethasone.
Oh.
Is that the main one studied here?
It seems so. The sources indicate dexamethasone has been studied much more often in clinical trials, specifically for antiemetic use, compared to methylprednisolone.
Got it. Now, this next part felt really critical. The sources highlight specific situations where you should absolutely avoid using steroid premedication for nausea. Can you walk us through those? This seems vital.
It really is. It shows how you have to tailor the supportive care to the main cancer treatment. So, number one, avoid corticosteroids when they're given with immune checkpoint inhibitors, unless the patient is also getting standard cytotoxic chemotherapy at the same time.
Immune checkpoint inhibitors. That's immunotherapy, right? Boosting the patient's own immune system.
Exactly. And steroids can suppress the immune system, so you don't want to counteract the effect of the immunotherapy if you can avoid it.
Makes perfect sense. Don't let the anti-nausea drug weaken the cancer-fighting drug. What else?
Okay, also avoid them for 3 to 5 days before starting CAR T-cell therapy, and then for a full 90 days after CAR T.
CAR-T, another advanced immunotherapy using engineered T cells.
Yep. Same logic applies. HER-T relies on those engineered immune cells being active. Steroids could dampen their function, which you absolutely don't want.
90 days after, that's a long window.
It is. And the last one mentioned is during lymphodepleting chemotherapy.
That's the chemo used to wipe out existing lymphocytes before things like stem cell transplant or TRT, right?
Correct. During those specific chemo cycles, the sources recommend a corticosteroid-sparing approach for nausea prevention. Basically, try to use other antiemetics if possible.
So the common theme is, don't use steroids if they might interfere with the immune system when the main cancer therapy relies on that immune system being active.
Precisely. It's about integrating the supportive care, not just tacking it on.
That's a huge takeaway. Okay, great. Let's cover the third main class from the sources, the NK1 receptor antagonists.
Right. Neurokinin-1 receptor antagonists. The drugs listed are aprepitant. There's an injectable emulsion form of aprepitant to fosaprepitant and rolapitant.
Okay. And the sources were super emphatic about one thing right away with these, how they must be used.
Absolutely. Non-negotiable, according to these sources. NK1 antagonists are never used alone for preventing CINV. They must be part of a combination.
A mandatory combo. With what?
With a serotonin 3 receptor antagonist, one of the citrons we talked about, and dexamethasone, the corticosteroid.
So it's always a three-drug regimen, NK1 plus serotonin blocker plus steroid.
For the indications discussed here, yes. That's the standard approach highlighted.
Why? Do they just not work well enough on their own, or is it about hitting different
It
pathways?
seems to be about hitting multiple pathways. They block the NK1 receptor, which uses a different signaling molecule called substance P. This pathway is also involved in triggering nausea and vomiting.
Ah, substance P, so it's another angle of attack.
Exactly. But blocking serotonin may be affecting prostaglandins with the steroid, and blocking substance P with the NK1, you get more complete control, especially for chemo that's highly likely to cause severe nausea.
Multi-target approach. Makes sense. What are they specifically approved for?
Preventing both acute and delayed nausea and vomiting. For chemo regimens known to cause these problems, especially the highly immunogenic ones, covers both initial and repeat cycles of chemo.
And did the sources give any sense of how much better things get when you add this third drug, the NK1 antagonist?
They did provide a specific statistic for aprepitant. Adding aprepitant to the standard serotonin blocker plus dexamethasone regimen improved the complete response rate by about 20%.
And complete response means.
Defined as zero vomiting episodes and no need for any rescue anti-nausea medication during the monitoring period.
Wow, a 20% jump in people having no vomiting and needing no extra meds. That really underscores why that triple therapy is the standard for high-risk chemo.
Yeah, it's a pretty significant improvement in control.
What about dosages? Did they mention specifics for aprepitant?
They did, for the oral form. 125 milligrams on day 1, then 80 milligrams on day 2, and 80 milligrams again on day 3. It's a 3-day regimen.
Okay, 125, then 80. And the IV form?
The IV form, fosaprepitant, or the aprepitant emulsion, is typically given just on day 1, but the dose depends on the chemo risk. For highly immunogenic chemo, it's 130 milligrams. For moderately immunogenic chemo, it's a bit lower, 100 milligrams.
Interesting. So even the dose of the NK1 blocker is fine-tuned based on how rough the chemo is expected to be. Another layer of tailoring.
Exactly right. It's all about matching the prevention strategy to the level of risk.
Okay, so wrapping this up then, we've looked at these three key classes from your sources, the serotonin 3 antagonists, the citrons hitting serotonin receptors in the gut and brain,
Uh,
the corticosteroids like dexamethasone, common, effective, but with a slightly fuzzy mechanism and some really important do not use situations.
Definitely.
And then these NK1 receptor antagonists, blocking substance P, but always used as part of that three-drug combo with the other two classes for those tougher chemo regimens.
And we pulled out those crucial details, the side effects like headache and constipation being common across the citrons, the cool delivery options like the granastron patch or a long-acting shot, planocitron's long half-life being a potential game changer for multi-day chemo,
Right.
the absolute need for that combo therapy with the NK1s, showing that multi-target strategy, and maybe most critically, those specific times, based on the literature, when you have to hold the steroids because of interference with immunotherapy or CRT.
Yeah, diving into sources like this really shows it's not just about handing out an anti-nausea pill. It's way more nuanced. Different drugs hitting different targets, specific timing, required combinations, and avoiding them altogether in certain cases based on solid evidence. It's about supporting the patient without messing up their main treatment.
Absolutely. It highlights how managing CINV is, well, it's a really sophisticated part of cancer care. You need to know the agents, how they work, and crucially, the whole context of the patient's treatment.
For sure. So here's maybe a final thought, something for you listening to mull over after hearing about all this from the sources. Given everything we just discussed, the different ways these drugs work, the precise timing, the combinations that are required, and those really specific contraindications based on the type of cancer therapy someone's getting, how does this change your perspective on just how incredibly targeted and, well, integrated antiemetic therapy needs to be within the bigger picture of cancer treatment?